Thanks again for coming out tonight. I'm going to be talking about crooked, twisted legs, and I titled it An Orthopedic Perspective of Bow Leg, Knock Knees, In-Toeing and Out-Toeing. And the reason I've chosen this is because it's probably the majority of the cases that I see where kids are coming in and parents are with their parents for evaluation of deformities. It's something very common, and hopefully I can shed a little bit of light on the subject. So I'd like to start briefly with the introduction to pediatric orthopedic surgery before moving on to the deformities. And the deformities, like I mentioned, that I'll address today are going to be bow leg, knock knees, in-toeing, and out-toeing. As Ms. Huddleston said, I did my medical school training at University of Pennsylvania. I did residency at Northwestern in Chicago, and then I did a pediatric fellowship at the Royal Children's Hospital in Melbourne, Australia. I followed that with the limb deformity fellowship at the Rubin Institute for Advanced Orthopaedics, which is at Sinai Hospital in Baltimore. I am part of an 8-person team, and we take care of kids and their pediatric orthopedic problems. My 2 senior partners are Larry Rinsky on the far left and Jim Gamble. And all of us have some unique subspecialties. Dr. Poon is a subspecialist in hip preservation. Dr. Imri, who's next to her on the top row, is a specialist in scoliosis. Dr. Hoffinger is a specialist in cerebral palsy. I enjoy deformities. Dr. Rinsky, he does everything and does it well. Dr. Chan is a new addition who does sports medicine. Jim Policy does scoliosis, and Jim Gamble, again, does everything in a lot of sports. But this is our team. We try to provide all the subspecialties within the subspecialty of pediatric orthopedics. But what is pediatric orthopedics? I usually just tell my friends, oh, I take care of kids and their broken bones, and they say, oh, okay, and that's about as detailed as I can usually get. But it's a little bit more encompassing than that. In addition to the bones, it's also the muscles and the joints. We take care of also some adults who will have pediatric conditions that will carry on, so we provide a whole gambit. And what makes it really interesting is that it's not just one age, but multiple ages, and they're all changing. And that will be highlighted a little bit in the talk tonight. When we think of orthopedics, frequently now I think we think of joint replacements, broken bones, and more commonly sports injuries. But the roots of orthopedics actually is related to pediatric orthopedics. The Latin word orthopedics was coined from the word ortho, meaning straight, and pious, meaning kids. And the idea was that it was the art of correcting and preventing deformity in children. The logo for orthopedics or the emblem is a sapling with a stick beside it and some twine to try to help straighten it out. And so this is our history, and it's one that I'm proud to be a part of. Tonight I'll be talking about deformity. Merriam-Webster defines deformity as a condition in which part of the body does not have the normal or expected shape. And the couple deformities that I'll be talking about, as I mentioned before, will be knock-kneed, bowed legs, in-toeing, and out-toeing. So first, starting with knock knees and bow legs. These are frontal plane deformities. So basically, when looking at someone from the front, we can kind of get a sense of their deformity. Knock knees is basically where the knees are literally knocking together. There's a space between the ankles, and clinically, we can measure this to get a sense of how much knock knee there is. The scientific term we'll use is Genu. That's the intramalleolar distance, or the space between the ankles. And sometimes we'll measure this to be able to follow it along in time. The opposite would be bow legs, and this is where you can get the ankles together, but you can't get the knees together. It's a real common deformity, and in this situation, to follow it along, we'll measure the space between the knees, or the intercondylar distance. We can also measure this probably more accurately with x-rays, and how we do that, we have a patient. We bring a camera in place, and we take an x-ray. They're standing for these x-rays, and they're positioned typically trying to get the kneecaps facing forward. And that's relevant because rotation can sometimes affect our measurements. What we get in place is a picture of the hips, knees, and ankles. And what we then can do is assess the alignment. In order to assess the alignment, we draw a line from the center of the hip down to the center of the ankle, and we see where does that go relative to the center of the knee. Ideally, it goes in the center, or really plus or minus a centimeter on either side. And depending on how far from the center, we can determine how much of a knock-knee or how much of a bow leg deformity is there. And again, we can watch this over time. Coming back to the definition of deformity, one key word in the definition is normal or is expected shape. And as it turns out, kids will change over time. Probably the most common time that I see kids for a bow leg deformity is going to be sort of in the early ages. They've just started walking. They've been bow-legged ever since they were walking, and they're probably somewhere around 2 years of age. And then later, the sort of latter group, from about age to 3 to 5, I start seeing the folks that have a knock-knee deformity. And this isn't by coincidence. Heath and Stahaley et al. Looked at how kids' bones will change their shapes in time, and they found that from 0 to 2 years of age, there was a propensity towards that bow-legged appearance. And the graph that is shown here with the knee angle here, varus refers again to the sort of bow-leg deformity, valgus referring to the knock-knee, and you can see that as time goes on, there's a pretty substantial and definite change. And so it's great. At this point in time, when I see the 1.5-year-old, I can say, you know what, this is probably going to get better. And sometimes there's a little bit of disbelief because sometimes it can be quite severe. But checked back a couple months later, we'll see some improvements. And likewise with 3 to 5 years, that's sort of the nadir where you start to see the most knock-knee appearance. And again, a lot of reassurance, and graphs can be helpful with that to suggest that this deformity will get better, but certainly will follow in time. So as an example, this is a little bit of an extreme example, but this is a young man who was 1 year and 10 months. I saw him in my clinic, and the parents were pretty concerned. His knees were really wide apart. But given his age, I said, you know what, it's going to be okay, and we're going to follow this along. If there's anything that needs to be done, we can take care of it. Well, 6 months later, they came back and they were so happy that things were getting better. And this is the same kid, 6 months later, quite a bit taller, not yet fully corrected. In fact, the line's still just touching the inside of the knee, but this was a couple months ago, and I'm still kind of going to follow him along. But there's definitely a trend towards the right direction, back to center. Now, sometimes unexpected things happen, and so, for instance, trauma. This is kind of a unique case, or not so unique actually, but an interesting fracture type. Fracture meaning any broken bone. And if you can look really closely here, you can see a little crack. This little crack on the upper part of the shin bone can sometimes be unpredictable. Even though it looks like it will heal straight, sometimes it will actually grow crooked, and it will create a rather significant knock-knee deformity. knowing this is going to happen and sort of a little bit of forewarning can be really helpful so that we don't overreact to when this happens. But the good news about this type of break is that it does actually tend to straighten out in time. It's known as a Cosin fracture for those interested. Other times, injuries can affect the growth plate. The growth plate is the part of the bone that does the growing, and if it's injured, it can sometimes create a deformity as the child grows. This young man found himself on the bottom of a football pile and had a pretty bad injury to his knee and had an injury to his growth plate and then developed a little bit of a bow leg deformity. Other times, infections can cause all sorts of crazy deformities. So we have a little bit of a bow leg on this right leg. This is a result of meningococcus, which can affect multiple growth plates and really is quite a bad actor because it can be very unpredictable what's growing, how much is it growing, and what the deformity is going to be. There are other metabolic bone diseases as well. So problems with vitamin D and and calcium is an example, rickets here. And they get some unusual changes of their growth plates. And this young lady who's from Nicaragua, or that I met on a trip to Nicaragua, had this deformity here. And the giveaway for the rickets is these widened growth plates here. And then there's a whole bunch of other things that just cause crooked legs, and we don't know why. One disease is called Blount's disease, and in the adolescent, it is commonly found in sort of the really heavy young man. Their legs start out normally when they're young, and over time, they develop a rather dramatic bow leg deformity. There are multiple forms of it, probably a little bit beyond the extent of this talk. There are some forms that will also happen in young kids. On the right side of the screen is actually one of my more favorite x-rays, but it's kind of a unique one where there are missing bones, which possibly caused this deformity. So, for example, on this one here, you can see that there's two bones in the lower leg, a lot like the bones in a chicken wing, and one's the tibia and one's the fibula. But this young lady has something known as fibular hemimelia, where she didn't develop that fibula. Actually, you can see just in the corner, there's just a little hint of it. But because of that, she's developed a rather knock-kneed appearance. So moving on to treatment, how do we treat these? A lot of these can be treated with observation. We certainly wouldn't want to act too early to treat something that might get better on its own, but we don't want to wait too late to the point that we have to cut the bones to straighten them out. So really treatment runs the gambit, and we'll go through each one. So I mentioned observation, and again, this is going to be particularly for the young ones, the 0 to 2-year-old with bow legs. There's certainly no real reason in general, if it's a sort of normal bow leg, to sort of be too aggressive about that, or the knock-kneed at 3 to 5 years. A lot of these we can watch. And a lot of times they'll get better largely by themselves. Bracing, there's a small role for bracing. I think some people are still a little skeptical about whether it's truly helpful or not, because some of these deformities will get better by themselves. But there does seem to be a small group in that age less than 3 years old with Blount's disease, but the infantile form, or the one that affects the young kids. So there's a small group of kids who have a very significant bow leg deformity, and those kids, when treated younger, it seems that it actually will help them. The next one is called Hemiepiphysiodesis, and this is a mouthful. But basically, the idea behind this is treating these kids by trying to modulate their growth plates. So that we can kind of tease the bone and sort of finesse it to grow straighter. And as an example of that, again, just going back to a little bit of anatomy of the bone, there's multiple parts that make up the bone. The epiphysis is sort of at the end, sort of up here. The growth plate, also known as the physis, and the diaphysis, which is sort of the shaft of the bone. And typically, the way the bone grows is that the growth plate lays down new bone, builds it on top of the shaft, and really ends up pushing the two ends of the bones away from each other. The idea behind hemiepiphysiodesis, which is to place a tether on one side of the growth plate so that the other side will grow. So here's the tether, and as it grows, we can see that bone is placed asymmetrically. In this situation, I made a straight bone crooked, but the idea can be applied the other way around. And as an example of the sort of powerful ability of something very small to affect big changes, this is a young man who's about 14 and a half years of age, who had a bit of a knock-knee deformity, and we proceeded to straighten him out by placing 4 little small plates, 8 little screws, and in a matter of 6 months, he straightened out. Now, we actually it's a little bit of coincidence that we happened to catch him just as he went through a growth spurt. This is actually a very fast correction and almost a little bit faster than I would have expected, for sure. But that's what we can do when there are little growth plates that we can kind of use. And in my opinion, if we're going to straighten the bones out, the best time to do it is just before the kids are done growing, while they're still growing, so that we can sort of harness the growth plates to help straighten it out. It's a much smaller procedure, it's better tolerated, and it's very effective. Once they're done growing, unfortunately, there's not much options if one wants to straighten out the bones, except for cutting the bones and straightening them out. And sometimes that can be a rather long process. Here's an example of a young man, about 16 years of age, again with Blount's disease, and which again is a bow leg deformity. And he has the adolescent type. So you can see down here that the line does not go through the center of the knee, but it goes rather on the inside. And he was having quite a lot of knee pain, and partly because I think that his joint line is no longer flat to the ground, but it's rather sloped. And so with each time he took a step, there was probably a little bit of side-to-side motion of his knee, which was causing him pain. Since he was done growing, there's no more little growth plates to modulate, and so it sort of leaves the only choice of cutting the bones. When analyzing this, here are the cuts that I decided to make, and as sort of planning, that's kind of what I wanted to do. When I draw the line again from the center of the hip down to the center of the ankle, you can see that we can straighten that out. It's an involved process, like I said, and so this is him through the correction. He had something called internal fixation, which is basically where I cut the bone, straighten it out, put a metal plate and hold it there. And then he had something called external fixation. And external fixation is just a way that we can use metal on the outside of the body to slowly make corrections. It's a good way to sort of check, double check, and make sure that we get what we want. And sometimes it can be very helpful. And this is the young man about 1.5 years out from his surgeries. All the metal is removed, and we see that his leg is straight again. I'm going to move on to in-toeing and out-toeing. And these are transverse plane deformities. And basically, if you look at someone from above their head looking down, sort of looking at which direction their feet are pointing. And you can see this when you go to the beach fairly easily. You can see footprints left, and you see the direction that the feet are pointing. And if you look carefully enough, you'll see that lots of people have feet that point in different directions. In general, most of them are pointing a little bit outwards, but some will point in and some will point out, and there's a lot of variability. The fun part about this is to try to figure out where is that turn coming from. This is a young girl who came and saw me about a month ago, and even though it doesn't quite show it here that much, her mom was concerned that the feet were turning in, and that when she ran, she tripped with some frequency. So the question I always go through my mind is, where is the deformity? What is twisted? And I'm just going to walk you through a little bit of the examination because the physical exam is the primary way that we'll sort of evaluate this. Whereas before with the Bowleg and knock-kneed, we were able to use X-rays. Here, it's really hard to get an X-ray of the twist of the bones. There's ways, but we use a clinical exam a little bit more. So we measure something called the heel bisector, and basically we take a look at the heel, and we look at a line that goes down the middle. And again, we sort of ignore the toes, but we look to see where this line goes to relative to the toes. So this yellow line here goes between the second and third toe, and this is a normal alignment for a foot. This, for example, is something called metatarsus adductus. It's a common shape of the foot in kids with in-toeing. And you can see here that the heel bisector goes between the fourth and the fifth toes as opposed to the second and third toes. So there's an inward twist. This is a different person. The next segment that I'll look at is the lower leg, or the tibia, or shin bone. And in this measurement, we're looking at what's the difference in the angle between the thigh and the foot. This is known as the thigh-foot angle. But basically, if the tibia is twisted, then the foot will look, there will be an angle between the long axis of the thigh and the long axis of the foot. And so as a better example, and so in this young child, notice the pants, she is straight. This is another example of a tibial torsion in a young kid. And here, if you looked at the thigh-foot angle, you'll see that he is markedly internal, somewhere on the order of about 40 degrees or so. So this would be an internal tibial torsion. Going back to our young lady, the next thing that I measure is the thigh segment. This one I have a little trouble explaining, but if you sort of ignore where the feet are and look at where the kneecap is pointing, you can see that the picture above here shows an internal twist of the thigh bone, and that's portrayed by the feet going far out. So this is with the kneecap pointing in. This is an internal twist of the thigh bone, and if you compare that to her external twist, again, so this is the kneecap pointing outwards. She has far more internal twist than she has external twist, and so her problem, or the cause for her in-toeing, is very likely due to her thigh bone having a twist in an internal bias. So in summary, she has a little bit of in-toeing. I will comment that it's amazing that the kids they'll oftentimes know why they're coming to see the doctor. They will oftentimes self-correct and do a doctor's walk or a doctor's stance. But you do see just a little bit of what the mom was concerned about, of that internal twist. And I would say that the twist is due to due to her thigh bone and the femoral aneurysm that she has, because everything else is perfectly straight. So getting back to the definition of deformity, it's relevant because the rotation in the legs also change over time. We think that due to packaging in the womb, the typical packaging in the womb, that the feet and tibias, or the leg bones, tend to turn inwards. Meanwhile, the hips tend to sort of rotate outwards. And as such, this is a common position for newborn babies, that their foot tends to be pulled inwards a little bit. That leads to some of the metatarsus adductus that I was talking about before. The leg also has an internal rotation, or the part between the knee and the ankle has an internal twist to that. And then meanwhile, if you look up at the hips and the thighs, they tend to be sort of externally rotated or turned outwards a bit. Now this will change in time, and typically it'll be slow and steady, rather slow, but steady until about the age of 10. So this is a graph of the internal twist of the leg bone. And at birth, you can see that it tends to be just below 0. This is sort of the internal side. And then over time, it starts to turn more externally. And so you kind of get that trajectory. You'll also notice that there's a huge variation, range of normal of about 45 degrees. So the variation in this is quite a bit, and it explains sometimes why one child does not look like another child. Similarly, the external twist of the thigh bone will change in time. And so the kids will start out here, somewhere around the 40 to 60 or 60 degree range, and over time that twist will decrease, like so. And again, these changes are going to be very slow, continuing till about the age of 10, where the changes are not as significant after that. Pediatricians frequently will tell their patients that this is going to get better. I'm told it's going to get better. This is going to get better. And the parents are really concerned when a year goes by and they don't really see much change, and then 2 years go by and they don't really see much change. But this is sort of like watching grass grow. It does happen, but it's a slow change. The foot progression angle is what the medical speak for what directions the feet are going. And it's the idea that if you drew a straight line, what's the angle of the foot relative to that line? And going back to the picture in the sand, the person on the left side of the screen has a little bit more of an external foot progression angle, or out-toeing, as compared to the person on the right side of the screen who has a little bit more of a almost straight ahead pattern. And again, I think both of these, I don't know who put these footprints there, but I think that these sort of both fall in the realm of normal, which again is a wide range of almost 30 degrees in either direction. These are clinical ways to measure it, and they're about as accurate as we can be, but the accuracy, one wonders, could the accuracy be better? And we do studies called Gait Analysis to try to get a better sense of it. So this is my plug for our motion analysis lab at Lucille Packard. In the motion analysis lab, we have the opportunity to put markers that on the skin that can give us a sense of the underlying bone structures. We can use mathematics to sort of equate what the joint angles are, and we can look in 3 dimensions, both from the front, from the side, and from above. And though this is not this young man's tracings, these are typical graphs that we'll get. The foot progression angle, again, that's sort of the direction that the feet are pointing towards. In this person is inside. The problem seems to be coming from the tibia, or the lower leg bone, or the shin bone. And then meanwhile, you see that the hip bone, or the thigh bone, is rotated externally. And so if you looked at individual components alone, it's hard to get a sense of what's going on, but the motion analysis allows us to really sort of get a dynamic sense of what's going on. When the twists in the bones get to be above 2 standard deviations, that's when we call it torsion. It's just more of a definition thing. In general, the sort of natural history is okay. In early childhood, especially for in-toeing, the biggest concern is that the kids are tripping with frequency. But that will, generally speaking, will get better with time. On the other hand, out-toeing kids, they tend to be a little bit slower, and this probably relates to some of the biomechanics of the feet. It turns out the joints in the foot tends to unlock when they're sort of turned outwards, and so you get that sort of flat foot, sort of floppier foot, and not as good of a push-off. Meanwhile, in-toeing tends to sort of lock the joints in the feet. You get a better push-off, a better platform to push off. And if you look at sprinters, you'll see that they have a tendency towards in-toeing. In adulthood, we can use gait analysis, and we do see that there's some compensations that are made for in-toeing and out-toeing, and that might put some additional stresses on the joints themselves. Having said that, there's not really any piece of literature that's really proven that. We don't seem to have a higher incidence of joint replacements in people who are in-toeing and out-toeing. And this is important to consider when we think about what we're going to do as far as treatment. The treatment should really reflect the problem. There are some problems that do happen, however, that can show up as in-toeing or out-toeing. And these are real problems that need addressing a little bit more urgently. The example above is something called hip dysplasia. It's frequently found early on around the time of birth, and it's a dislocation of the hip. Untreated, it will lead to sort of an in-toeing pattern and earlier arthritis of the hip. Below is something called a SCFE, or a slip capital femoral epiphysis. And the injury is actually through the growth plate up here, and that leads to the foot turning outwards. That's typically something that starts to happen in adolescence. It doesn't always have to be sort of a sudden thing. It can sometimes be a very gradual thing. But in both situations, in the situation of a SCFE, it comes to light because it's pretty painful. Down in the legs, there's something called miserable malalignment syndrome. This is hard to sort of explain why it hurts so much. But basically, what's the syndrome, or the constellation of findings, is that the thigh bones tend to be internally twisted, and the shin bone tends to be twisted in the opposite direction, or externally. The W position is something that gets a lot of attention to, and that's the idea that some kids will sit with this sort of W shape to their legs. One theory is that this helps them with balance by increasing their base of support. But what it also does, it sort of promotes an internal twist of the thigh bone and an external twist of the leg bone. And some people believe it's important and helpful to sort of discourage this position if possible. And then down in the feet, sometimes you can have flat feet, and flat feet themselves are fine. But when they're rigid and they're not flexible, they can be painful. And one cause of this is something called the tarsal coalition. In general, flat feet tend to sort of be turned outwards, and this thing called tarsal coalition tends to be sort of a rigid outward twist of the feet. Moving on to treatment. So this is the same treatment scale that I used before, but when treating in-toeing and out-toeing, the options are a lot more limited. We don't really have the ability to brace and do growth plate modulations. And we found that over time, through several studies, that bracing is largely ineffective for managing this problem. And so we're sort of stuck between just leaving it and letting it be and surgery to cut the bone. And that's an important discussion that one would have with their surgeon in deciding what to do. Again, the long-term sort of prognosis of having in-toeing or out-toeing in general isn't that bad, and really hasn't been shown to be associated with osteoarthritis, although it may increase some of the stresses across the joints. Osteotomies, or cutting the bone, is really what it sounds like. It's cutting the bone, such as here or down here, rotating it to sort of straighten it out, and then locking it in place, typically with some metal, either a rod, in this situation, some pins, or a metal plate. So in conclusion, knock-kneed and Bowlegs, these are frontal plane deformities. You can see them from the front. Especially early on, many of these will improve with time. The treatment is age-dependent. I think oftentimes we can sort of watch these for a while, but if one chooses to take care of them, then it would be, I think an ideal time is just before the kids are done growing, and take advantage of their growth during the sort of pubertal, around the time of puberty. And then after that, cutting the bones to straighten them out is required. In-toeing and out-toeing, these are transverse plane deformities, again looking from above. There's a wide variation of normal, and these will also change with time. Our treatment options are limited for these, and sort of treatment options can be considered and discussed with the surgeon. So, thank you for your attention, and if there are any questions, I'd be happy to answer them. Yeah.
Do these conditions tend to be symmetrical or one-sided?
There's not sort of one pattern. They can be both symmetric or one-sided. Yeah.
And then do you treat it differently if it's asymmetrical?
Generally not. I think that the options are oftentimes for the families to decide whether they do or don't want it addressed. I think there is a tendency, if it's one-sided, to sort of create a match pair. But sort of always have to weigh the pros and cons of surgeries.
Yeah. How long do you wait before starting to consult an orthopedic surgeon?
I would say that frequently you can wait until sort of the maybe 9-10 years of age, maybe even a little bit earlier for girls, because they'll sort of start their going through puberty a little bit earlier. But having said that, I think that my experience has been frequently that families want a little bit more reassurance, and the pediatricians, as much as they have a good understanding of the situation and explain it very well to the parents, sometimes it's out of the pediatrician's hands, and I'm happy to see those folks and provide some reassurance. And I think I'll oftentimes say, well, if, two people say say the same thing, it must be true, right? And usually that's helpful for the families. Yeah.
Sports like gymnastics or horseback riding often lead to bowed legs?
I don't know. I'm not sure, actually. I mean, certainly the idea of bow legs, and I wanted to pull a picture of a cowboy, sort of comes to mind. But but I'm not certain whether or not there's something else about that that might lead us to that sort of stereotype. I'm not sure. Yeah. I'll have to look it up. Yeah.
If a child does show in-toeing or out-toeing, should a parent, the kid will most likely grow out of it, but should the parent do anything in terms of behavioral action or?
Yeah. So I'm a little torn on how to answer. I'm not yet a parent. But I realize that kids will frequently do things that they want to do, regardless of what the parents want them to do. I'm not entirely sure if this is one of those battles to fight hard on, because I think that the overall outcome is pretty reasonable. You know, the kids will very likely continue to run and play and do everything that they want to do. I think that it's not unreasonable to discourage some things like W sitting. Or one thing I didn't mention would be sitting on their feet and sort of that internal twist of the leg bone. But sort of how hard do you push? I think that it should reflect the severity of the problem. And so in general, I sort of encourage parents to sort of gently remind their kids, but I don't think this should be a major battleground to address. Yeah.
What led you to choose this specialty?
Well, I think it kind of picked me. I really love taking care of kids, and I have a very engineering sort of mind, and so the sort of pediatric orthopedics sort of seem to fit both. But I'm definitely sort of slanted towards the gait analysis and some of these external frames. I like measuring angles. I like trigonometry and sort of pediatric orthopedics sort of fit, and deformity correction sort of fit pretty well. So, yeah.
Is there any level of genetic influence? Like if it's for me, it's my niece. Her mom was pigeon-toed. Does that matter?
Absolutely. There's definitely a genetic component, but or at least it's definitely written about. I frequently will ask the families to show, sort of, if they're bringing their child in for in-toeing or out-toeing. I say, well, does anyone else in the family have it? And they insist that they're not. And so I do think there's a genetic component. I'm not always able to prove it during a visit. I don't tend to focus on that too much. So, yeah.
Great. So racial component.
So for Bowlegs, the disease called Blount's disease does tend to happen in more of an African American population. I did my fellowship in Australia, and I also did some research in medical school on Blount's disease. And my fellowship director said, well, I'm sorry to disappoint you, but you're not going to see any Blount's disease while you're down here. And I was like, huh, that's interesting. And I never thought about that. So yes, there's definitely a genetic component. Asians, so something I didn't know, Asians tend to have a little more bow-leg appearance than the Caucasian population. And I think the group was a Turkish population tends to be a little bit more knock-kneed than the Caucasian population. So there's definitely an ethnic component or a racial component to it.
What about nutrition and things where there's severe nutrition? You were in Haiti, I believe.
Yeah. So there are conditions like rickets disease, which is a vitamin D deficiency, whether they don't get enough through their diet, that can cause distortions of the bone. And so we did have one patient there, and then the patient that I had shown here on the presentation was from Nicaragua. So there's definitely some element of nutrition as well. Well, thank you very much for your attention.